Securities and Banking, or DSB, is hosting this event in coordination with the DC Department of Behavioral Health, Office of Healthcare Ombudsman, and in collaboration with stakeholder organizations, the DC Behavioral Health Association, the University of the District of Columbia, and Children's National Hospital. My name is Philip Edmonds. I'm a director at DSB and the moderator for this webinar focused on Mental Health Parity and Addiction Equity Act requirements, or to use its acronym, MPEA. I'm very excited to be with you today, and on behalf of DSB Commissioner Karima Woods, I want to thank you for joining us. This virtual roundtable is scheduled to run from 12 to 1 p.m. We have a great panel of mental health experts and mental health parity experts who will provide important information and connect you to relevant resources. We are going to cover a variety of topics, including mental health access, insurance coverage, your rights under existing federal and DC law, and available services in the District of Columbia. So what is MPEA? It's a law that requires insurers to cover mental and behavioral health no more restrictively than physical illnesses of the body. Specifically, MPEA requires most health plans to apply similar rules to mental health and substance use disorder benefits as they do for medical and surgical benefits. So if you or someone you care for, a student, a young person you engage with, needs help or is struggling to pay for mental health services related to depression, anxiety, mood disorder, eating disorder, substance abuse, addiction, or alcoholism, and/or you have questions about services a health plan should cover, this is the event for you. Before I introduce our speakers, I'd like to first invite DSB Deputy Commissioner Sharon Shipp to give welcome remarks. Sharon. Sharon, if you're on, you may be on mute. Okay, in the absence of the Deputy Commissioner, let me say a few things. First, we know that COVID-19, the pandemic, and the resulting economic recession have negatively affected many people's mental health and created new barriers for people already suffering from mental illness and substance use disorders. During the pandemic, students and young adults were prevented from socializing as they normally would. Routines were disrupted, feelings of isolation intensified, and uncertainty about the future was magnified. Some quick facts for your consideration. In 2019, Pew Research found that the total number of teenagers who experienced depression increased 59% between 2007 and 2017. Then the pandemic came along. JAMA Pediatrics published an analysis that included over 80,000 youth across the globe last summer, which indicated that youth mental health difficulties during the pandemic have likely doubled. In October 2021, the American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association joined to declare a national emergency in youth mental health. I'll take a quote from Congressman Frank Pallone, who at a health subcommittee meeting on April 5th, 2022, said that while the need for mental health services is greater than ever, Americans of all ages face a range of barriers to the care they should get. These barriers include stigma and discrimination, provider workforce shortages, and concerns over the cost and coverage of care. Concerns over the cost and coverage of care is exactly what the MPEA requirements are designed to address. So with that, I'd like to introduce our distinguished panel. First, Ms. Patricia Thompson is the Ombudsman Program Officer at the DC Department of Behavioral Health. Mr. Mark Levoda is the Executive Director at the DC Behavioral Health Association. Ms. Maud Holt, DC Healthcare Ombudsman with the DC Department of Healthcare Finance. Dr. Serena Butler Johnson, Director at the University of the District of Columbia. Counseling and Wellness Center, and Dr. Laura Willing from Children's National Hospital, co-director of the Anxiety Disorder Program at the Department of Psychiatry. Each panelist will have approximately 7 minutes to speak. We are going to let all 5 experts make their presentations before we allow questions. When the presentations are completed, we will begin our question and answer session. So with that, I'd like to turn things over to Ms. Patricia Thompson. Ms. Thompson.
Thank you so much. Good afternoon, everyone. My name is Patricia Thompson. I'm with the Department of Behavioral Health, and my goal in the next few minutes is to talk a little bit about accessing behavioral health coverage, whether it be public or private health insurance, and a little bit about services for transition age youth. Next slide, please. I think what's important to note is that behavioral health is health. We talk about mental health should be and is an integral part of your overall health, as your physical health is. I think an important item to note is that 64% of the people that were treated for substance use disorders within our DBH certified provider network actually were also treated for mental health services as well. Prevention is possible and treatment works, and it's important to know that every day people recover. Next slide. Next slide, please. As we talk about how to approach healthcare, it's important to note that we are looking as a whole person, that physical health, your mental health, substance use is really an integrated care model, and it's important to have parity between both. Next slide, in terms of access to services. What's important, as Mr. Edmonds has already spoken about, is the Mental Health Parity Act and Parity in Addition Equity Act really ensures that behavioral health services should have the same ease of access as physical health services, which means that it should not be financially more restrictive to access behavioral health, or treatment limitations and access should not be more restrictive. One example is if you're provided unlimited doctor's visits on a chronic health condition, such as diabetes, then you should be able to access unlimited visits for a mental health disorder. Next slide, please. What to do if there's an issue, and we'll talk a little bit more about that. There's a link there that's provided to access or contact the health insurance. You can work with the DC Healthcare Ombudsman and other entities that are provided there as well. Next slide. I think what's important to note is how do you actually access the healthcare benefits? It's important to know that we have many different options in the District of Columbia in terms of health insurance. You can be funded through a public program such as Medicare and Medicaid, or local dollars with the district, the Healthcare Alliance. If you don't have any insurance, please reach out to dchealthlink.com for assistance to access care and services or coverage. What services are provided are actually, in terms of coverage, will be given based upon your insurance company. How do you access those services are actually through contacting the health insurance. You can also access services through contacting the provider directly. And if there are any challenges in accessing services, our office, the Department of Behavioral Health, and the Healthcare Ombudsman are both available to assist. I've provided a number of ways or services that you can access via telehealth. The District of Columbia provides face-to-face services with our community-based providers, or also services in the public school system. In order to link to these providers that are here, it's important you can contact the Access Helpline at 888-793-4357, and they can direct you to services. The Department of Behavioral Health has mental health supports that are in the community. We can access freestanding mental health clinics. Those links are provided in the slides that are there. And it's also important to note that we have school-based services in public and public charter schools, and you can go directly to the school for assistance. Next slide, please. The District of Columbia Department of Behavioral Health also offers same-day urgent care services. The urgent care clinics, that means you can get a same-day appointment. We have adult clinics, and we also have clinics available for children and youth that are provided there, information. And we also have the Assessment and Referral Center, is referred to as the ARC. And also, that's a same-day appointment. You walk in and you can get referred immediately for substance use treatment. We also have a mobile crisis service. That's our community response team that's available for individuals who are in psychiatric crisis or need behavioral health supports and they just can't get to a provider. We have that both for adults and also our children's and adolescents mobile psychiatric services, our CHANCE team, and they provide on-site services. Last but not least, we also have our CPEP, which is our comprehensive emergency psychiatric clinic that's available for psychiatric stabilization, and then as needed, referral to more intensive treatment. Next slide. I think what's important is let's talk a little bit about targeted services that are available within the Department of Behavioral Health for those 16 to 25. For those who are experiencing a first episode psychosis, we have a specific program with Community Connections that can help manage individuals and their symptoms and also provide supports around employment, education, and also support those others around the family unit as well. For those who, to really ensure that they're getting through that first time, and you can contact them directly through the Access Helpline and contact from there. We also have supportive services, which are supportive employment services. There are 2 providers within our network. Those services actually help individuals access a job. They can work on their resume writing, they can have a plan and help them get focused around a particular career or career jobs and access those placements. Next slide, please. We also have housing. And this is a critical factor, especially to stabilize individuals who may be homeless. This particular program at Wayne's Place are able to help individuals who are transition age youth from 18 to 24 and a half and support them independently with a plan to move forward for independence. The contact is provided there. We also have through our TAY program, a transition age youth program, ways to that young adults can be engaged with cooking classes, creative writing programs, and gardening projects. The contact person, Mr. Atkins, is provided there. Next slide, please. I think also we have available our TAY, our Transition Age Youth Academy and Speakers Bureau. This is really a training ground to help young adults talk about their experience related to behavioral health, mental health, and or substance use services. The contact, Mr. Harris, is provided there, and it's called Dream to Soar. And that's really a way that people can use their voices to advance information about access to care and education. And how to access services and what their own individual experiences have been. Next slide. Next slide, please. We also, most importantly, have Adolescent Substance Use Treatment Expansion Program, which is our A-STEP providers. And these are actually individuals who are between 12 and 25 and providing counseling, intervention for transition age youth. So those are direct services, counseling services that will help around substance use prevention and treatment. Next slide. I do want to make sure that everyone is aware for all residents, regardless of age, we have a 988 number, which is our suicide and crisis lifeline. That's available 24/7. We have trained crisis counselors that are available to speak with individuals who are experiencing a suicidal ideation. Next slide. Most importantly, we also want to add that we have a mental health hotline, and that's really being used before a crisis exists. So that number is 1-888-793-4357. It's again 24 hours, 7 days a week. You can actually speak with someone to talk about your feelings and get the support that you need, and potentially they can also connect you to services as needed. But there is a trained mental health specialist that's available, and it can be used by anyone that's a district resident. Next slide. So thank you all. We will take questions at the end of this program. Thank you.
That's right, Ms. Townsend. Appreciate that. And next, our next panelist is Mark Levoda. Turn it over to you, Mark.
Thanks. Hello, I'm Mark Levoda. I'm the Executive Director for the District of Columbia Behavioral Health Association. I'm grateful to DISB for inviting me to join this panel and to the members of our audience for taking time to join us for today's discussion about mental health and addiction parity. Next slide. The District of Columbia Behavioral Health Association is the trade association for organizations that deliver mental health or addiction recovery services to district residents. Our member organizations and affiliate member organizations join together to support high-quality whole person care. Our work includes policy advocacy with the DC Executive Administration and the Council of the District of Columbia, training and technical assistance, including automatic membership in the National Council for Mental Well-Being for all of our member organizations, and community engagement. Next slide. I always like to share the takeaways of my presentations up front. I hope this will draw you into the rest of the presentation, but if not, you'll at least know some of the things that I think are most important for you to take away. For today, I want to reinforce that behavioral health conditions are common and treatable, share some information about the ways that you can find help for yourself or someone else in need, and give some information about how mental health and addiction parity requirements strengthen people's ability to access behavioral health care with no more difficulty than gaining access to physical health care. Next slide. The District of Columbia Behavioral Health Association envisions a District of Columbia where every resident with a mental illness or substance use disorder engages in high-quality, whole-person care. As you can see from this simplified chart of the district's behavioral health system, our system is built to recognize that treatment is only part of what's needed for emotional wellness and mental well-being. We have to have service available for different times of people's lives and that address both social risks and personal choices. In the district, we also have to recognize the roles of trauma and racism and offer multi-generational services. The best whole person care is also whole family and whole community care. Next slide. Mental health and addiction parity laws, regulations, and policies are useful tools to ensure that we're on track, keeping behavioral health services just as accessible as physical health services. As we work to ensure that people receive appropriate care based on their needs and preferences in a timely manner, behavioral health parity requirements are particularly useful to assess access, network adequacy, and telehealth. Next slide. Behavioral health parity allows people to expect access to behavioral health care like they expect access to physical health care. Parity rules apply to categories of benefits: inpatient, outpatient, emergency, and pharmacy. For some plans, there may be no behavioral health coverage at all for some of these groups of services. There's also no requirement for the behavioral health benefits to be as generous as the physical health benefits. What parity requirements do say is that whatever behavioral health benefits are offered, those behavioral health benefits shouldn't be harder to access than to access physical health benefits in the same group of services. One of the ways to test whether care is being restricted any differently for physical versus behavioral health services is finding out what's required to have services authorized. If it's necessary to get permission from an insurance carrier to schedule a behavioral health visit, but not for scheduling a physical health visit in the same group of services, that could be a parity violation. If an insurance carrier doesn't have special documentation requirements to gain approval for physical health care, but does for behavioral health care, that could be a parity violation. If the insurance carrier lets people choose which therapy to go for their physical health care, but makes people try different options in a specific order for their behavioral health care, that could be a parity violation. Parity requirements also mean it shouldn't be harder to get timely care. There shouldn't be a big difference in how hard it is to find a behavioral health provider open for new intake versus finding a physical health provider open for new intake for the same group of services. There shouldn't be substantially longer wait lists for behavioral health providers than for physical health providers, and it shouldn't be any longer of a wait to be scheduled for an intake to an open provider or to be scheduled for a treatment visit. Next slide, and my apologies. Parity requirements also play a role in how insurance carriers think about what types of providers are available in their networks. Parity requires insurance plans to make sure that travel time and distance are not substantially greater to access behavioral health services than to access physical health services. Parity also requires the right mix of providers to be available for different behavioral health conditions, just like for physical health conditions. Some of the timely access requirements that I described previously can also be used to check whether insurance plans have enough behavioral health providers in place to make sure that there's just as good of a provider network for the plan's behavioral health services as there is for the plan's physical health services. Next slide. In the past few years, we've all shifted to meeting through technology more and faster than most of us ever imagined. Telehealth has become a substantial component of how healthcare is delivered, including behavioral health care. Parity rules can play a role in how telehealth is used in behavioral and physical health care. As one example, if an insurance carrier allows people to request in-person physical health visits, but requires people to use telehealth for all of their behavioral health visits, that might be a parity violation. If an insurance carrier charges different copays for physical health telehealth sessions versus for behavioral health telehealth sessions, that might be a parity violation. And if the basis for determining physical health provider payment rates for telehealth visits is substantially different than the basis for determining behavioral health provider payment rates for telehealth visits, for example, if we're reimbursing physical health in-person care and telehealth at the same rates, but reimbursing behavioral health in-person care and telehealth at different rates, that might be a parity violation. Next slide. People should have no more difficulty accessing behavioral health services than they do accessing physical health services. Parity rules are an important tool to move us all toward high-quality whole-person care. If you or someone else needs help, there are resources available. Treatment is effective, and recovery is possible. Next slide. Thank you again to DSB for the invitation, and to each of you for participating in today's presentation. I look forward to your questions at the end of our panel.
Mr. Levoda, thanks for that. And I do want the audience to start thinking about some great questions you've heard from Ms. Thompson and Mr. Levoda. Start thinking about what you may want to ask those two panelists. You heard a plethora of information, so start jotting down those questions. Next, I'd like to turn to Ms. Maud Holt, who is from the DC Healthcare Ombudsman Office. Ms. Holt.
Thank you. Good afternoon, and thank you to the Department of Insurance, Securities and Banking, and thanks to each of you for joining us today for this wonderful workshop that we're having and information sharing. My name is Maud Holt, and I'm the Healthcare Ombudsman for the District of Columbia. We're going to share some information with you that we hope that you will find very useful for you, and that you will be able to use our office for you. You've heard information that came from both Ms. Pat Thompson and Mark Levoda. And the information that I'm going to share with you will help you use your benefits better, and that if you've denied those benefits, that you will know where you can come and get help. The Office of the Healthcare Ombudsman operate under two separate and distinct legislation. Next slide, please. We operate under two separate and distinct legislations. We have the Health Benefit Plan Bill of Rights that in 1998 was effective April 27, 1999, DC Law 12-274 and the DC Official Code Section 44-3301.01. And it was amended on November 20th, 2012 to comply with the Federal Patient Protection Act, better known as the ACA of 2010. And we also, next slide. And then we also have the Ombudsman Statute, which allows us to help. There are still some employees in the District of Columbia that are covered under the federal benefits. And those are employees that were employed by the District of Columbia before October 15, 1987. We also are able to assist those employees with their benefit up to the part that we will have to send it for an external review. We cannot send your part for an external review. We have to work with OPM for that. The reason for requesting an appeal is that if you've had an adverse benefit determination resulting in a denial, reduction, limitation, termination, or failure to make a payment on a benefit, or delay of a benefit to a member regarding determination about medical necessity, appropriateness, or level of care or healthcare setting, whether a benefit is experimental or investigative, a decision to rescind a coverage. We don't see rescind coverages anymore. Very rarely we see a rescind coverage. A member's eligibility to participate in a plan, whether a wellness incentive had been properly applied, or whether a member was given a reasonable alternative standard for satisfying a wellness plan when required. And I talked about employees hired after October 1st. Those are federal employees. Now, for a federal employee, we can help you with your first level of appeal. We do help federal employees on their first level of appeals to help you get the information that's necessary to go back to your federal plan. And we've talked to federal plans on what authority that we have to do that. And the authority that give us that is the Ombudsman Statue. We actually have a statute, and we've shared that with the plans, with the commercial plans, what authority that we have. And now they understand that we have that authority because the law gives us that authority to help the employees, the district employees, or anyone that works in the District of Columbia or live in the District of Columbia that have the federal employee, the health insurance, that we can help them to do that. We can help you up to the point that it has to go to an external review. We cannot take it to the external review for you. For employees that, the next slide, please. Then for an expedited appeal, the expedited appeals are usually medications that we have. And my staff usually turn expedited appeals around within 24 to 48 hours. Because if someone has a medication or needs something that has to be expedited, we work with the insurance to send those. And most times those are medications that we work to get an answer back so that you can get that medication. And most times that is what that is medication that you're trying to get. And sometimes it's the start of a chemo drug or something like that that we're trying to get. Now, unfortunately, what we don't see a lot of is mental health appeals. There are some, but it's very few mental health appeals. And what we get on the mental health side, it's only appeals after the parent has already paid for the service and they have not been reimbursed by the insurance company. And oftentimes, sometimes we do have cases that we work with DISB where we have sometimes therapists refuse to provide the insurer with information to help the insurance company adjudicate a claim. And that is the part that there has to be information given for an insurance company to be able to adjudicate a claim. And that's no different than if you had a medical claim, there has to be information to be able to adjudicate a claim. They're not asking for your psychotherapy notes. They're asking for information enough to be able to adjudicate a claim. So that information that we do work with sometimes DISB to help get the claim paid for the person. And if the therapist refuses to do that, sometimes it's very difficult to get that claim paid. In order for us to do that, there's a request. The next slide, please. There's a request that you must do for us to begin the process is an appeal form that you must sign. And that appeal form is your authorization form that you will sign. The next slide, please. That you will need to sign for us, giving us the authority to work with your insurance company and gather information from your doctor and from other people that will give us that authority to work on your behalf. And once we receive that information, we may proceed. We review the next slide, please, after we receive that. We do work with receiving pertinent documentation, and some of the information that we get we receive, and the clinical staff, it goes to our clinical staff. There's a lot of research done. They work with your physician, work with other places that they can get a specialty in the American Cancer Society, other teaching institutions that can help them with the information that's necessary to help overturn a denial that they have. And sometimes it's just sending additional information back to the insurer that's not there, that was not in the original information that was sent, to help overturn the decision that you had. And then sometimes it has to go to the external review organization in order for it to do it. The next slide, we show for you the mental health appeals that we've had: inpatient services, outpatient, partial hospitalization, substance abuse, eating disorder, adaptive behavior, and on the undetermined is a high amount in which we are asking the staff to look down to see what the undetermined are. We should be able to determine what those undetermined claims are over in the mental health, because that's a high number for undetermined. And then we looked at the mental health appeals in a 5-year period, and you can see what they are in the 5-year period. Inpatient was the highest number, and those are usually children in the residential treatment facilities. Some of those are for your inpatient services in the hospital that we have. That's there. The mental health appeal outcomes, you will see the decisions that have been made that are there on page 12. The 13 will just show you the slides. And the success rate, we've closed 44 successfully, 5 unsuccessfully. We have 15 that we're waiting for determination on. And then we provided you with some helpful links. And certainly with our partners for the Department of Insurance, Securities and Banking, that they help us with the interpretation of contracts that we may have. And sometimes on some decisions, we have to go to the Department of Labor to assist us on some. But thank you for your time, and we'll wait any questions that you may have. Thank you very much for your time today.
Ms. Holt, thank you very much for that presentation. I'm sure you'll get a lot of questions about the appeals process. So appreciate that. And want the audience again to start thinking about your questions that you want to ask the panelists. I think now I'll turn things over to Dr. Serena Butler Johnson from UDC.
Okay. Good afternoon. I am Dr. Butler Johnson. I am the director of the Counseling and Wellness Center at UDC and a licensed psychologist. So I'll just start by talking about what do we know, what are the basics about mental health in young adults in 2022. So the average age of onset is 18 through 24 for the majority of mental health disorders. And as was discussed by Mr. Edmonds previously, the isolation due to the pandemic has been a driving factor in the increase of mental health issues for our young adults and for our college students. This has been one of the real negative impacts regarding COVID for folks' mental health. The harms of social media are also a main factor in mental health issues. I often talk with my clients about it being unfair to them to compare themselves to their lives are like the behind the scenes. They're comparing themselves to photoshopped highlight reels of other people, and that really creates a lot of difficulty for them. The young adults in this day and age, there are many strengths and points of resilience, but that is a whole nother conversation, but one certainly worthy of having. With respect to college students specifically, 1 in 5 college students has a diagnosable mental health disorder. Anxiety and depression are the mental health disorders that are most common amongst college students. And in our center, at the Counseling Center at UDC, we would say on any given year, we see about 70% of UDC Counseling Center clients, they present with anxiety. And according to the JED Foundation, which is an organization focused on suicide prevention and mental health awareness, over 60% of students felt so overwhelmed by anxiety at least once within the past 12 months. Regarding depression, roughly 45% of students who first sought counseling, they reported depression. And again, also according to the JED Foundation, almost 39%, almost 40% of college students felt they were so depressed at some point within the past academic year that it was difficult for them to function. All of these mental health symptoms certainly have a result on academic performance, persistence, and retention. These symptoms make it difficult for college students to focus on their academics and perform to their academic potential. So rates of mental health disorders have certainly increased over the past. This chart looks at mental health trends over the past 9 to 11 years. And for the first time, we did see, on a positive note, in 2021, decreases in substance use. That was the first time within 9 years that has been measured in college students, that we have seen a real decrease with that. We also saw in 2021 a decrease in students suffering with hostility and anger as one of their presenting concerns. But we have seen increases in mostly everything else, namely anxiety, social anxiety, which has even increased with COVID as folks return to their social spaces, and depression continues to increase at high rates. So I lead a counseling center here in the district, and so I want to share a few things about the role of college counseling centers. One of our main points is that we provide accessible care to students. So the idea is that we're able to hopefully see students within a short period of time, and we provide services. They are time limited because of demand versus capacity issues. We have gone many years, almost 14 years, without having session limits, but at this point, again, due to demand issues, we've had to cut back in terms of session limits. So at that point, we do refer students to community-based providers for longer-term care. We provide individual and group counseling, psychiatric services, group therapy. Some centers or many centers provide medication management. We do not. And ultimately, our counseling services at the center are to help students feel well and support their academic performance, their retention at the university. Our services are offered for free, and services at many universities are free. Some do bill to the students' health insurance plans, and others charge a small fee. So these are just some slides related to the counseling center. Right now, we do provide virtual and in-person services. We are able to see students for up to 10 sessions a year. However, there are many situations that will warrant an extension. And so that's certainly a process that we do utilize. And we have a crisis line so that you could students can call our counseling center main line at any point, evenings, after hours, weekends, holidays, and they will be able to talk with a crisis counselor. So the next 2 points, I think the next 2 slides are really the most important from my perspective as an outpatient practitioner. When folks are deciding to seek treatment, I do recommend that if they are thinking about it, then it's best to go ahead and get started with their research. So determining how much your symptoms are interfering with your daily life, this can be a big deal in terms of deciding whether you seek treatment or not. This grid or chart here is an NIH fact sheet that you can look for, and it is useful. It talks about if symptoms are mild and they're under 2 weeks, you've experienced them for under 2 weeks, then maybe you can engage in some self-care and, receive support from family and friends and this kind of thing. And if it's more than 2 weeks and symptoms are becoming extreme, or, it's difficult to get out of bed, it's difficult to care for some of the things, to have enjoy things that you typically enjoy, then it may be time to look for treatment. I would say, again, I recommend that folks do this as soon as they really start to think, is this necessary for me? Then you can go ahead and do the research. And if you change your mind, then, you can pull back and not schedule the appointment or cancel an appointment. And this is an area where family and friends can play a role in helping folks look for a provider. So we engage in this process as students come towards the end of their session limits, and we need to transition them to a provider off campus. It is a lengthy process. It can be very difficult. So students may search through their insurance companies. Psychology Today also has a great therapist finder where you can filter by insurance company so that you could find providers that are in network. Oftentimes, quite honestly, that is very difficult to find because the majority of therapists and psychologists in the area are not in network with insurance companies. So then they would go down the route of looking for out-of-network practitioners. And the out-of-network practitioners can provide a statement with dates, diagnoses that you could submit to your insurance company and get reimbursed. You'd get reimbursed for the rate that your insurance company says is reasonable and customary for your geographic area. Usually there is a gap, and so there is some financial responsibility for the patient or their family. Again, this is a piece that, quite honestly, it can be challenging. So I really suggest that friends and family, that may be one area that you can really help. It's good to manage expectations, have hope and faith in the process. Know that finding a good fit is very important. The therapeutic alliance is really the #1 predictor of a good therapeutic outcome. So it does make sense to make sure you get someone that you can connect with, but also be sort of patient with the process. So as you go through that process and beginning with therapy, know that it's not going to necessarily be it's not going to be potentially all that you want in, say, the first or second session. But again, I think having some patience with that process, and family and friends, this is a way that you really can support friends and family. This process, it takes a lot of time, energy, resources, and someone that is depressed or has another mental health issue oftentimes does not have the energy, motivation, or resources to engage in that process. We've already talked about 988, and that is the suicide crisis lifeline. It was previously called the Suicide Lifeline, and that's available for call or text at any point. And there's also the crisis line, the text line, and you can text home 741-741 to connect with a crisis counselor at any point.
Great, thank you, Dr. Butler-Johnson, for that great information that you provided us. I'm sure there are going to be a lot of questions headed your way at the Q&A session. At this time, our last panelist, I'd like to turn it over to Dr. Laura Willing with the Children's National Hospital. Dr. Willing.
Thank you so much for having me today. Good afternoon, everyone. My name is Dr. Laura Willing. I'm a child and adolescent psychiatrist at Children's National, and I specialize in anxiety disorders and gender dysphoria in youth. Next slide, please. Okay, so we've heard from a lot of excellent presenters today, and you might be noticing a theme across the district and the country. Need for mental health care has risen. That is especially true in the pediatric population, and it can be very hard to find mental health care. The purpose of today's webinar is to talk about mental health parity and how you should be able to expect to have adequate networks and resources to mental health care through your insurance company. So how can you find this care? We know that it's becoming harder and harder, especially for our youth. So I just want to encourage you not to give up, right? It is hard right now. It's not you doing something wrong. And so keep at it. I'd recommend calling everyone, literally everyone on your insurance panel, and to find out, are they accepting new patients? Do they have a wait list? If they are accepting patients to a wait list, get on every single wait list that you can. It is important, as our previous panelists talked about, to have patience and look for a good fit. But there is just so much need right now, and we also want you to be able to get the healthcare that you need as quickly as possible. So To do that, you can go to your insurance company's website or call them on the phone. If you flip over your insurance card, there's a number on the back to call. That's a great place to start. Psychologytoday.com, as you just heard about, is another place where you can filter by psychiatrist or psychologist or therapist. You can see what they specialize in. You can see what insurance plans they participate in, or whether they will submit out-of-network claims for you to the insurance company, or whether you're responsible for doing that. Just the fact that we're talking about, right, out-of-network coverage or submitting out-of-network claims indicates that we are that there might be a mental health parity violation, right? Because we don't talk about that in the same way for physical health. Something else you can request from your insurance company is a single case agreement, also sometimes called a network exception request. And so that means if you have called everybody on your insurance company's network and you are still having trouble finding someone, geographically reasonably close to you who has openings in a reasonable amount of time, and you can't find that in network, you can request that your insurance company grant you a special exception to cover someone out of network. And that might be called a single case agreement, or it might be called a network exception request. And so that is something that the provider you find would have to agree to enter into with the insurance company just for your specific case or your specific child. But it's something to ask for. And knowing the language can be really helpful. You can also access services through your school. So if your child has a 504 plan or IEP, individualized education plan, you may be able to request counseling services in the school as part of the accommodations in the 504 plan or the IEP. Many schools have a school counselor or a school psychologist who may be able to provide some support, or they may have groups at lunchtime you could ask about. Every school is different, so it's important to ask what resources are available at your child's school. There's also increased work in the district around school-based behavioral health. And so finding out if that is available through your child's school. Not all schools have it so far, but they're really ramping up that program. You can also see your pediatrician or your primary care provider. So if you're waiting and you're on all the lists, right, and you really wanted to get in to see a therapist or a psychologist or a psychiatrist, in the meantime, seeing your pediatrician or child's primary care provider can be a really good place to start. They may have ideas for referrals, and they may be able to help provide some medication management in the meantime if that's needed, or to provide other brief interventions. And you can also call the DC Access Helpline, which is listed here, which you heard about earlier in the presentation as well. Next slide, please. Okay, so let's say you've done all of that, you're calling the insurance company, you're on all the wait lists, and you really want to advocate for your family. That's why you're here, that's why you're at this webinar. You know that you and your family deserve the very best care, and you deserve to be able to use your insurance to get that care that you or your child needs. So if your insurance network is not adequate, or you cannot access care in a timely manner, you have options. You have ways to advocate for yourself. You heard about filing appeals before. If you have insurance through your work or a family member's work, you can contact the HR department if you feel comfortable doing that. You don't have to do that. You don't have to self-disclose any diagnoses for you or your children. But if your HR department is the one who is technically purchasing the plan, they might be a good advocate for you if you feel comfortable. You can also file a report to DSB, the Department of Insurance, Securities and Banking here in DC. You can also file a complaint. And I know DSB really wants to help, but if they don't know about potential mental health parity violations, it's hard for them to act on it. So the more information that they have, the better able they are to act and to try to improve mental health parity in the district. You can also make a report through the Kennedy Forum. So if you Google Kennedy Forum, that's a national organization that is dedicated to gathering data and advocating for mental health parity across the whole country. And they work at a national level, and they also help individual states work on this parity issue. As you've heard before, mental health care is important, and it's a necessary part of healthcare. Mental health care is healthcare. So you deserve this and your family deserves it. So if you're on the phone talking with an insurance representative, what should you say? What words can you use? What language can you use to help escalate your concerns and advocate for yourself and your family? So of course you already know to ask to speak to a supervisor or a manager. If the person that you're talking to isn't going to be able to help or isn't going to be able to escalate your concerns, then ask to speak to someone who would be able to. Using specific language, such as mental health parity violation, right? You don't have to yell or get angry, but you can be calm and firm in advocating for yourself and your family. And say, I'm concerned this is a potential mental health parity violation. I need to talk to someone who can help me address that, right? You can also use terms like inadequate network or non-quantitative treatment limitation. Okay, these are fancy terms and complicated, but it might signal to the person that you're talking to that you know what you're talking about. You know about mental health parity law. You know it applies in the District of Columbia and in the whole country. And you know how to report complaints and file potential violations with Department of Insurance, Securities and Banking. So that might help get your claim, your concern escalated. And then, as we talked about before, asking for a single case agreement. Next slide, thank you. Telehealth is also a great option. It's not going to magically improve everything, right? It doesn't increase the number of providers in your network necessarily, because the provider still may need to be licensed in DC. So it doesn't automatically mean that you could just start seeing someone in California, right? But it can reduce barriers to care. It can help you access the care more easily, and you're less dependent on geography and transportation. So maybe you could see someone on the opposite side of the district where it might take you, an hour to travel there. It can really make it more convenient. It's not ideal for every situation. There are some mental health diagnoses that in-person care is really more appropriate, but if telehealth is helpful for you and your family, it can really help reduce some of those barriers to care. Next slide, please. Okay, so when should you seek help? Really, if you are concerned about anxiety or depression, anger, hostility in your child or a family member or yourself, that's a great time. But some specific things to look for, especially in youth, are changes in sleep patterns. So sleeping more than usual, right? Sleeping all day, or having trouble going to sleep at all, sleeping much less. Changes in appetite, eating more or eating less. Changes in energy level, feeling sad, down, irritable, grumpy, snapping quickly, being angry more easily, being withdrawn, isolating, staying in your room all the time. And that's a significant change, right? Trouble with concentrating, that's new, trouble with substance use, feeling anxious, worried, or having panic attacks, you should seek help. If you've experienced a trauma, if you're having flashbacks or nightmares, hallucinations, paranoia, delusions, suicidal thinking, self-harm, aggression, violence, and homicidal thinking. These are all signs that you should not wait. You should get help as soon as possible. And I think you've heard most of these resources already. Using the DC Access Helpline, the number is there. CHAMPS is the Child and Adolescent Mobile Psychiatric Service. That's 24/7. You can call that. They can come to your house and help you. And they are not the police, right? That can be very helpful. Calling 988, which is a national hotline. It's kind of like 911, but it's for mental health. It's quite new. They do route you to callers based on your area code. So if you have an area code that's out of the district, you might be routed to a different location at first, but you can let them know where you are physically. Not that they would necessarily automatically send someone to you, or for, if you're concerned about privacy, but it would help get you to the right resources, right? You want DC specific resources, so you want them to know that you're in DC. Here's also the number for the National Suicide Prevention Lifeline. And of course, if there is imminent safety concern, right? If someone is acutely in danger of hurting themselves or someone else, and you need someone there physically, 911 is also a good option. Next slide. Thank you very much, and I look forward to all questions.
Dr. Willing, thank you so much for that, for your presentation. A lot of great information. I appreciate that. So I think at this time, let's start our question and answer session. Please use the chat feature on your device to write and send us your questions. Folks who are calling in, please use *3 to raise your hand and *3 to put your hand down. A member of the DISB team will read your question and direct it to a specific panelist. So without further ado, let's get to the questions. And I think I have the first question. And I think this goes to Ms. Holt. Quick question. What is the statute of limitations for filing an appeal for an adverse benefit determination?
180 days.
Excellent. Okay. I hope everybody heard that 180 days from the point in time that you get that adverse determination. You have 180 days.
There are some, in some policies, there are some exceptions, and that's what we look for. There are some exceptions, and we've gotten some exceptions. We had one that we did, the person had a mental illness and they were in the hospital, and we read the policy, and because they were in the hospital and had this mental illness, we looked at the policy and they allowed us to file it late due to the fact of their mental illness.
Yes, this is Idris Abdullah. We have a question in the chat. Sometimes young adults show symptoms of mental health concerns but refuse to get care. What tools are available? What tools are available for parents and caregivers to help those young people get the services that they need? And I'm going to direct that to Dr. Welling.
Thank you very much for that question. Can you explain, are you asking about how to direct people to the correct provider service level?
No, the question was basically what tools are available that will help parents and caregivers to help the young adult get the care they need, since oftentimes those young adults, although they're showing symptoms of mental health concerns, they may be refusing to get care. So what tools would you recommend?
I think it's around stigma, Dr. Welling, that children have a stigma. There's a stigma around mental health, and there's a lot of it in the Black and Brown community. And that's what he's asking. What are some of the stigmas and tools that can be used to have them to be able to get treatments? What he's asking.
Thank you for clarifying that. This is a really tough issue. It's really hard. There is a lot of stigma around mental health concerns. I think there's a couple of different tacks you can take. So finding something that the child or the teenager or the youth would find acceptable can be a good place to start. If you're in a faith community, if there is a faith leader that could provide counseling, if that would be less stigmatizing, that's one option. If there's someone in the school setting, right, that really reduces a barrier, because that's where the child is, right? If it's where they are for school or for some other community event, finding help where they already are. They don't have to go to another location, another place, to a mental health, right, facility, even if it was outpatient. Similarly, starting with the pediatrician, right? There's not very much stigma about going to see your pediatrician. Everybody goes to the doctor. Everybody has well child checks and visits, and you often need that for school physicals. So starting there can be another really good place. But it is really tricky. And I think letting the child or the young person know that that the parents don't have stigma around mental health, that the community doesn't, that people are supporting them, and that they deserve the best care. That would be my advice.
We have another question that was directed specifically to Dr. Willing. And the question was in terms of mental health professionals listed with one's insurance company. what happens if the professional listed with the insurance company are no longer accepting new patients? And we understand that they should get on the wait list, but how long would you consider a reasonable wait time for an appointment? And if this time passes, do you recommend seeking out-of-network care?
That's a very good question. It depends on a lot of different issues. So the severity of the illness or the concern, right? And your ability to pay for out-of-network care, right? And so some families are going to be in different positions than others. If you look up what most insurance plans and what most organizations recommend as a reasonable amount of time to wait for an intake appointment, the answer is 7 days. I think that's very difficult to find. I'm not saying you can't find it. I'm saying it's very difficult, and most places have wait lists that are much longer than that. You know, weeks to months is probably more typical of what we're experiencing right now in the district on average. If you think your child or your family member or yourself can wait that long, you can. Or if you have the ability to go out of network, that's a great opportunity to seek care quickly, and then you could stay on the wait list for other places. But usually when you go out of network, you have to pay up front, and then you try to get reimbursed from your insurance company after the fact. And so that can be a barrier because not everybody has the ability to pay up front, especially if we're talking about weekly therapy, right? Those costs can add up. If it becomes more serious or more acute, right? If you're talking about self-harm, thoughts about suicide or thoughts about hurting other people or psychotic symptoms, then it would be a good time to go to the emergency room to seek emergency care. So it really depends on the severity of the symptoms and how long you can afford to wait. But the technically correct answer is 7 days. I hope that answers.
Let me ask you this question. I think I have this question. I think my claim has been unfairly denied. What's the first thing I should do? So do you encourage that person to file an appeal, or should they appeal with the insurance company first? What's your recommendation?
Are you asking me?
No, Miss Holt.
Oh, Miss Holt, okay.
First thing a person should do is always file for an appeal. And most insurance companies tell you that you file an internal appeal first. However, the Ombudsman's office under the Ombudsman Statute, even though there's the Bill of Rights for commercial plans that tell you that you have to go to the insurance company. However, the Bill of Rights statute allows anyone, and that's for people on this call, it allows you to come to the Ombudsman's office for us to help you on a first line of appeal.
Thanks very much.
So always when you get a denial, file for an appeal.
Thank you.
We have another.
Go ahead, Idris.
The question was, how do you recommend avoiding or minimizing the public stigma for seeking mental health issues? And I want to direct that towards Ms. Pat Thompson. Again, how do you recommend avoiding or minimizing the public stigma for seeking mental health issues?
So I think through COVID, there's been a reduction in some of the stigma, but that still remains in the community. I think really, as the doctor already talked about, looking at going to a pediatrician or someone that the individual trusts. We're working on the stigma. The Department of Behavioral Health and many agencies are working on reducing stigma. And I think it's really finding an entity or someone that the person is comfortable with at the end of the day, so they can talk about what the challenges are and really normalize the fact that accessing behavioral health services, substance use and mental health services are something that is fine. It's appropriate, and everyone should and can do it. I think also Mark Levoda actually talked a little bit about being able to use text messages through some of the new access and platforms that are out there to talk to individuals and not just face-to-face necessarily, but starting maybe with a text with some of the resources that are available.
Excellent. This next question goes to Dr. Butler-Johnson. If you're a parent who is dropping their kid off at college for the first time, and you're concerned about their mental health, but this particular college or university does not have a counseling wellness center like UDC does, what do you recommend that parent to do? What are some resources that they should look to at that university?
So one, depending on where the university is, you might start by also talking with someone in your like student affairs or dean of students office and seeing if they have any recommendations. Also, the health services or whatever medical unit you have on campus, they may also be able to provide recommendations. Another university that does have a counseling center would also be great for the student. So that's, I think that's where I would start, is maybe your dean of students. They should know of some referral sources, and also your health services center.
Idris, do you have another question?
It was answered in the chat, but I don't know if everyone has been accessing the chat. And that question was, does Hipaa apply to mental health services as well? And I think that's a very important question. Does Hipaa apply to mental health services just like any other kind of healthcare service? And again, Dr. Welling, did you want to take a shot at it, or Mr. Levoda?
Mr. Levoda answered in the chat. I'll let him take this one.
Yes.
Thanks. Yes. So HIPAA does apply to mental health, and a separate part of the federal code, 42 CFR Part 2 is what it's called, offers extra privacy protections for substance use treatment. So people do have really robust privacy protection for mental health care or for addiction treatment, just like they would for any kind of medical or surgical care. Actually, in the case of addiction treatment, it's an even stronger level of privacy protections, just to make sure that people feel comfortable seeking care.
Very good. And Dr. Willing, one of the slides in your presentation mentioned NQTL. It's a non-quantitative treatment limitation. Can you just describe to people what that is?
Absolutely. This is sort of the crux of the ongoing mental health parity concerns in this country. So, Mr. Levoda gave a very nice overview of different types of things that might be potential mental health parity violations. And when they're quantitative, like if you're talking about the number of visits you're allowed to have, that's really easy to measure, right? So the number of visits that you might be allowed to have for physical health, and the number of visits you might be allowed to have for mental health, it shouldn't be any more restrictive for the mental health visits. Or the criteria for determining that should be no more stringently applied for mental health than physical health. That's pretty easy to measure, and mostly insurance companies have handled that. So the quantitative treatment limitations, like having a similar copay or cost sharing or coinsurance, those are numerical and those are mostly resolved. However, there's a lot of other ways that are non-quantitative that are harder to prove, right? So, you heard every time we talk about these potential mental health parity violations, or we say it might be a parity violation, is because to prove it, you have to compare what's going on in the physical space and the mental health space of the same insurance plan. And sometimes that can be like comparing apples and oranges. And so it's sometimes hard to prove, which is why DSB needs you to file reports if you're concerned there could be a mental health parity violation, so they know where to go to look. But so like some examples of non-quantitative treatment limitations would be not having enough therapists in the network, right? So if you have to wait, if the wait list is 3 months to see a mental health therapist, but the wait list to see a physical therapist is only a week, that's a pretty big difference. And you might say, well, that could be a potential non-quantitative treatment limitation, mental health parity violation. Another one that Mr. Levoda described is step therapy. So that means if the insurance company says you have to try this medication and then this medication and then this medication before we will pay for the one that your doctor prescribed, if they do that more often or more stringently for mental health than physical health, that could be another non-quantitative treatment limitation, mental health parity violation. There's a lot of other examples, but those are the types of things that we're seeing where it really reduces access to care for mental health.
Thanks so much. And I think we're running out of time. We could stay on for another hour. I just want to ask two more questions. I asked the panelists to indulge us. Are there two more questions in the chat feature, Idris? And we'll just ask those and we'll close the forum.
Yes, there are a number of online groups claiming to help and provide mental health services. Any thoughts on social media in this space? Any thoughts on social media in this space? Patricia Thompson, did you want to respond to that?
I think the only thing I can really say about this is really there are individuals or agencies that have done this for a number of years that are tried and true. So we know to go to some of the professional organizations, APA, the American Psychological Association for reference. We had also Psychology Today that's also there. National Association for Mental Illness, NAMI, is also a platform that you can go to. I think you have to do your due diligence on looking, knowing a little bit more about the organization that's there, that's on social media, and just really looking through and doing some research before you really connect to them via social media.
Excellent.
I don't know if
Last
anyone
question.
else had anything to add as well.
And this last question goes to Ms. Holt. If I have coverage in another state, but spend substantial time in DC due to work or school, should I expect to encounter access issues with my insurance? And are there protections afforded to me in DC, even though my coverage is technically in another state?
The issue is that where does your insurance sit to? Is the insurance sit to in the District of Columbia, or does it sit to in another state? That's what makes the determination. If your insurance is covered by the Department of Insurance, Securities and Banking here in the district, then the jurisdiction is here in the District of Columbia. Now, if it's not, then it will be covered by that other state. And the insurance laws differ by state.
Okay, great. Listen, I think we're out of time, but I want to thank each and every one of the panelists, the organizers, and the audience for your attention and participation. At this time, I want to turn to Deputy Commissioner Sharon Shipp to give closing remarks. Sharon.
Yes, thank you, Philip, and thank you to the panel for just an incredible, informative conversation and discussion. Apologies that I was not here earlier to give you all the proper welcome. We were experiencing some technical difficulties, but I do want to thank you all for joining us today for our forum, Understanding Your Mental Health Benefits, Access and Equity. I hope you found it helpful. And again, as Dr. Willing said, we want to help you. But the only way we can help is if you tell us about your concerns. So if you have questions about the information that was shared today or would like to know more about DISB's programs and services, be sure to visit our website at disby.dc.gov or contact us at 202-727-8000. Also, remember to follow us on social media. And thank you again for joining us today.
Thank you, and that's the end of the forum. Thanks so much.